Welcome to the Excellence in Training Academy, where trainers come to grow at excellenceintrainingacademy.com. I'm very pleased to have with us this week Jeff Sych. Jeff is a registered psychologist who has dedicated his private practice to the well-being and recovery of public safety personnel. Jeff is trained in the assessment and evidence-based treatment of mental health conditions that arise from public safety personnel service, but prefers to present on building resistant and resilience so that public safety personnel stay psychologically healthy and put him out of business by not needing his services any longer. Jeff is a co-author of a 2022 published peer-reviewed research study showing positive effects of high-fidelity critical incident stress management programs on the mental health of first responders in Canada. He's currently engaged in conducting 3 other research projects funded through government grants in collaboration with the University of Regina, the Canadian Institute for Public Safety Research and Treatment, and 1 other research project in collaboration with the University of Calgary. The focus of the research is on different aspects of delivering public safety mental health wellness programs and their effectiveness. Jeff is an ICSF approved instructor for critical incident stress management peer support courses, including assisting individuals in crisis, group crisis intervention, psychological body armor for emergency services and healthcare, and resilient leadership for emergency services and healthcare. Jeff has a current certificate in critical incident stress management from the University of Maryland, Baltimore County, and he is the clinical director of 9 critical incident stress management teams, first responder, hospital, and corporate based. He provides expert consultation on mental health wellness initiatives, critical incident stress management team development, functioning, and has participated directly in a critical incident stress management interventions. Jeff has for the past 6 years, Jeff has trained over 2,500 frontline public safety personnel and 100 leaders in emergency services and critical incident stress management peer support, traveling throughout the province of Alberta, which is where I'm based, an initiative to establish the Alberta Critical Incident Peer Network, a 24/7 peer-led driven network of trained peers who can provide evidence-informed peer support to those members impacted by the traumatic experiences they are exposed to during the routine course of their operational duties. So, Jeff, welcome to the Excellence Training Academy.
Great. Thank you for the invitation to be here.
Now, the last time I interviewed Sheridan Taylor, he talked about resources from a few different organizations, and then he told me that I needed to reach out and connect with you, that you are really, the programs you run are the gold standard for peer support within Canada. And so that's what I wanted to talk about, is kind of some of the best practices and peer support programs for selecting people, training them, managing them. But maybe we could start just kind of a broader sense first about critical incident stress management. We hear that term CISM a lot, and sometimes we throw these terms around without really defining them or understanding them. So can you talk a little bit about the broader umbrella of critical incident stress management?
Sure. Critical incident stress management, number one, it's a broad term, and there's many different models about it, but there's really only a few models that have research standards of practice and have the evidence that say that they work. So critical incident stress management really adheres to the idea that creating psychological immunity, resistance, resilience, and then the ability to recover from the impacts of stress, number one, is best done by those that are integrated into the public safety personnel's life already. That it's really about having the availability of resources both to prevent the injury, respond to the injury, and then connect people who might need more. So critical incident stress management is really based on a model over 30 years old that really says that the absolute benefit of peer support is having that support from somebody who doesn't need to have it explained what you went through or what your job is or the type of stress or the family stress that makes it hard to do your job, that there is an inherent understanding. The next thing about CISM peer support is it really is based on not I'm a peer, come talk to me. It's being able to say who in my time of need, either during the crisis or after, am I comfortable talking with? And then the final thing is having the peers that are trained to recognize those that might need more, to actually hand them over or link them to the services that are best able to provide treatment or resources afterwards. We tend to see failures in peer support systems where, number one, we sort of hear this idea as, well, we're going to create our own. We know what our members need. And unfortunately, we also hear we know what our members like. Well, liking something doesn't necessarily mean that it's effective. And we see a lot of probably a proliferation right now of individuals creating, marketing, selling, starting all these different programs that they say work or that they've adapted to work without the safety of any research that proves that it actually works. So that's a little bit about CISM, and it's a model of over 30 years. It's very structured in the type of conversation that you have. But just to be clear, the conversation happens before the injury. It's preparing people for what they do in their work so that they actually, number one, start developing a plan early in their career to know what to do to look after themselves, know what to do when they are injured so they can bounce back, and then know what to do if they need more. So we call it the 3 R's: resistance, resilience, and recovery model, by that really integrated component of peer support. Now, what's really important, and the other sort of thing that gets under my skin, is when organizations and individuals actually ignore the research out there. So the Canadian Institute of Public Safety Research and Treatment out of the University of Regina has published studies, has looked at best practice. They looked at the prevalence study, pan-Canadian prevalence study of psychological injuries in our public safety personnel. And just give you a couple of scary statistics. 44.5% of public safety personnel meet the criteria for 1 or more mental health conditions as a result of their work. Suicide rates are 3 times that of the general population. And in the blue paper that came out of CIPSRT, it absolutely said, here's what organizations need to do. Number one, organizationally led, leader-led programs do not work. That they need to really be peer-supported programs where people can access the supports and services when they need it at a time that works for them, in a manner that works for them. Yet what we see is organizations absolutely instituting leadership-driven, organization-driven programs and ignoring the best practice research coming out of really what is the Canadian Centre of Expertise.
Excellent. Now, University of Regina, is that Nick Carlton that's involved with that? And did a interview with him, and that was a few years ago now. So, like you say, staggering statistics. Now, when you look at, you talked about prevention, response, and then connecting people with further resources. It seems to me that when we look at critical incident stress management and peer support, that we miss the first part in a lot of cases. We miss the prevention part, the front end. And we talked about that in your bio, is that your goal is to give people the ability to go through a career without necessarily needing your resources to put yourself out of business. Is that something that you see where we tend to focus on the response and then some of the connection piece, but we miss the front end in the prevention piece?
Absolutely. I think the biggest failure of CISM peer support programs are that they wait for something to happen in order to respond. And number one, the amount of resources needed to do that, the time it takes to do that, but also the time to recover is so much more staggering, both on an injury load on the individual as well as a workload on the peers. But for over 30 years, the whole idea of preparing people for the type of work that they do, having them develop a plan, almost like a mental health plan, recognizing the signs and symptoms early, knowing what to do about it before the injury occurs, is really what's been instituted, but is one of the number one things, as you said, that organizations and peers fail to actually operationalize. So to give you an example, CISM, which is based on what we call the ICISF model, the International Critical Incident Stress Management Model, formerly called the Mitchell Model, developed by George Everly and Jeff Mitchell, has always had the component of resistance and resilience in it. George Everly is a Johns Hopkins psychologist who developed the Johns Hopkins resilience model, which is actually built in and embedded into the CISM program, But when you actually look at people that are training in it, people that are instituting the program, we don't do that. So they leave that third out, which is actually the biggest component of what we see preventing the injury. And the analogy that I give people is that, when you go to work the first day, your orientation tells you where to park, tells you where to put your lunch, tells you where to go to the bathroom. It tells you, all the different things. But we are shocked at how people are not prepared for what they are going to see in the line of work that they do, whether it is enforcement, whether it's corrections, whether we work a lot with hospital-based teams. We have people that show up with this idea of, I'm going to go and do this job, but nobody really tells them in their training or their experience what it actually means to do the job. And we see that there is a risk of those that are new to the new to the industry being overwhelmed by not being prepared to know what they're going to see, whether that is in a correctional facility and dealing with mental health issues or suicides or any other injuries. The enforcement largely what is accepted is a lot of calls are mental health related. We look at even our hospital-based teams. Wow, I never thought that I would have patients that died. I became a nurse or whatever in order to help people. Fire, EMS. People are drawn to these industries because they see contributing in a positive way, but they don't necessarily understand that the outcomes are not often positive. And that is actually a big factor and risk for creating a psychological injury. So the resilient and the resistant component is such an important piece that it is being missed, or they are using programs that have not actually proven to work under the realm or guise of resistance or resilience, or they do it one-off, but they never follow up. And any resistance program is something that needs to be continually delivered with high adherence to the model, high fidelity, and really done by peers, not by leaders or people in the organization.
And so that's such an important piece, as you described, that we fail to give them the resilience and resistance tools up front and prepare them for. I think that we also have seen over the years, the other piece of that is that sometimes we set them up for failure. So we look at some of these statistics and we say, hey, this profession is going to screw you up. And you're going to have all these problems, and you're going to be divorced, and you're going to have this, and you're going to have that, as opposed to saying this profession will change you, but it can change you for the better. You can grow as a result of this experience. And that instead of saying stress is bad and here's all the bad things, then we can look at stress as enhancing. What are the benefits of stress? Why do we experience this, and what are the positive things? Is that another piece of this, that we need to step away from setting people up and programming them for the negative, and have them just understand some of the data, and then give them the tools to say, this does not happen. We can give you the tools to prevent some of these. And if you experience some of these things, then there are additional tools to help you in that moment.
I think it's even more fundamental than that. Number one, we need to stop talking about PTSD. Number one, it's not the most commonly occurring psychological injury in our public safety personnel.
Right.
However, it's almost become the gold standard of, I have to achieve this diagnosis or this injury of PTSD to be worthy of whatever it is.
Yes.
Whether it be a WCB claim or whatever. But what we know from the statistics is depression, anxiety, substance use, relationship discord, on and on and on, are at higher rates than PTSD.
Yes.
But if we asked your audience to self-identify who has PTSD, who has depression, who has anxiety, number one, what we start to see is we see people that go, oh, I don't relate to that, or I'm not going to acknowledge that. But what if we just talked about stress? And when I do my resiliency seminars that are part of preparing people to be peers, part of instituting their peer program, I say, who here can relate to stress? Then I ask them to define what stress is. And very few people can tell me what stress is. They can tell me what causes their stress, which is what a stressor is. But what we do is we can spend about 30 minutes on saying, did you know that there are 5 ways that stress shows up in our body? Physically, emotionally, cognitively, behaviorally, and then spiritually. And here are some of the indicators from these different domains that your body is telling you that you're under stress. Now, what if I told you that there's about 36 different proven ways to cope with stress and reduce it, scientifically based? What if I told you and taught you the top 6 that you could do? Would you be willing to do it? Now, what if I said to you that if you do those on a regular basis, the research says that your stress response can reduce down by about 80%, and that your recovery time can be truncated by about 80%? And I'm not sure if you've ever interviewed Kevin Gilmartin, who wrote a book called Emotional Survival for Law Enforcement. He did research. He's actually proven this. So it's funny how we have this research. We even have people that used to be in enforcement that have gone to become psychologists that sort of study their own industry, that put it out there. That's largely being ignored, where we have people within organizations, whether they be leader, frontline, say, we know better. Well, the rates of injury, the WCB claims, the number of people that are not returning back to any of the industries that are public safety tend to say that what people are doing is not working. So it's time to hold people to a standard that says, show us the evidence. And let's talk about what evidence is. Empirical evidence must meet a standard where the science talks, not the person selling the product talks. And we're missing that. That we hear a lot of really good marketers. We have a lot of really good people that are going out there and giving the sales pitch. But when you say, show me your data, they don't have it. So, it really is, if you work in the public safety, public, services field, hold your organization to a standard that says, oh, you've brought in this program, show us the research. Number one, how are you going to evaluate that it's working or changing? And how do we make sure that it's not working for just the organization, that it actually is working for the people, the most valuable resource of that organization, which is the employees? And that's what we often see the tension between, which is the organization or the leadership goal can be very different in the type of program and the delivery for what actually the members need or want or will benefit from. And we have people making decisions based on either a good sales pitch, the best of intentions, but poor information. I jokingly say that, you're not going to call a paramedic, you're not going to call a psychologist if you're having a heart attack. So why are we expecting organizations, leaders, people that don't have the background or the training to actually be responsible for developing these programs or instituting these programs? Go to CIPCERT, go to the research, go to the people that know what they're talking about because they can prove it, and base your programs on what we know works, not on what we hope will work.
That's such a critical piece, and we're starting to talk about the evidence-based and research-informed. But again, it's sometimes there's a misunderstanding of evidence, and like you say, we get caught up with the sales pitches. And this is what we see: is every time there's some topic that's the flavor of the day, all of a sudden everybody is suddenly an expert in teaching that topic, as opposed to taking a step back and saying, you know what, that's not my area of expertise, but here's some people I can direct you to that will provide that great training. Now, you talked about the concerns or possible danger with leader-led programs. Can you talk about the difference between leader-led and leader-supported? Because I think the support from leadership is critical, but they're not necessarily the ones that should be leading or delivering the services. So can you talk about the differentiation? And maybe it's just in my mind, but can you address that?
Sure. Well, I think a leadership-driven model is really focusing, or the perception of the individuals is that it's focused on the needs of the organization or the leaders.
Right.
And so there isn't necessary inherent buy-in that, are they doing this for us, or are we doing this to either tick a box or to keep us, the shifts filled or whatever it is. So there's also a natural skepticism. And I think that what we recognize is when people are stressed or injured, our thinking changes, and our suspicion and our ability and willingness to accept things comes from more of a maybe anxiety or fear-based. So leadership-driven models also tend to create some concerns with individuals, which is, if what I share, if I access, is it going to be career limiting? am I going to be somehow labeled as injured or not as worthwhile or not promotable? And people want to tell you that this has gone away, but it has not gone away.
Right.
It's gone underground, to be honest with you. But we absolutely know that when you ask people where do they want to receive the supports, number one, their spouse, number two, their peers. Where do they not want to receive supports? EFAPs, employee and family assistance programs, and leader-driven models. So we are creating programs, if it's a leadership or organizationally driven program, that you're going to have, but nobody's going to use because there is that lack of trust in who's it there for. I'm not saying that all leaders are creating models that are not healthy for their members. What I'm saying is they're creating programs that a segment of their members, their staff are not going to access, probably the people that need it most.
Right.
So when we look at organizational leadership supported models, what we really go back is to, what is that resilient leader? Well, a leader is really somebody who people want to follow. It's somebody who shows that vulnerability, has clear communication, makes it feel safe, that they're decisive. And so what a leader supported model is being able to say, we are working to allow you to create this for yourselves with our support. And we don't want to know anything about it other than, is it being worked and what can we do to improve it? So I really think that if I go back to it, organization and leadership models, what I would say is those are like management models. They're almost imposed. Here's a number, here's a place, here's the thing you need to call, you need to access. Where I think that the leadership supported model really is the true essence of leadership, which is that modeling by example. Hey, if you need support in any way, go and reach out. We have confidence in these people. We have confidence in this program. The information isn't going to get back to us. This is purely for you. We've set it up for your benefit. And I think that that's probably the best way to understand it.
Excellent. Great explanation. Now, we've talked a little bit about resilience. So you talked about resistance, resilience, recovery. And resilience is a term that we hear a lot. How do you think about, or how do you define resilience?
Well, let's go to CIPSR and talk about their definition, because if we, again, have a common language in any industry, it's really important that we have language that is global. So let's go to the definition of what resilience is. It is the ability to be able to bounce back after some sort of, I'll say, stressor. Now, beyond that, what are the components of resilience? Well, we now have this tri-factor theory of resilience, but most organizations or programs focus on one that you've touched on earlier, which is we respond after something has already happened. But resilience is really about preparing people for the likelihood of stress in their life and what to do about it. So it's the proactive building of support services, self-awareness, ideas of what stress is. It really is education, not only about the jobs, what you're going to be exposed to, life, transitional life periods, and what to do in response to stay healthy. So that's the proactive. Then you have the reactive resilience, which is what we naturally default to as human beings to get through stressful times. And then we have the recovery, which is, what's my plan that if my focus on sleep, if my focus on, eating healthy, socialization, if those skills that I've used to cope with stress don't work, what's my next go-to plan? And it doesn't need to be formal mental health or a physician. Who's your go-to? Who are your people? What's your plan? And so it really is the tri-factor theory of resilience, is being prepared in advance, knowing what to do when you're impacted, and not waiting for somebody to come to you and say, hey, that was a really crappy day. Are you okay? And you going, oh, no, I'm not. It's being able to say, I'm happy having a crappy day. I'm not okay. And I'm going to institute my plan. And then the recovery, which is when the resilience plan doesn't work, it really is knowing which door to go through, because it is the worst time to try to figure out where to go when you are already feeling at your worst. So most organizations, most programs really focus on the reactive resilience. Oh, we're going to go and do CISM peer support once people have had this horrible thing happen. And there's a couple of things about that. Let's go back and talk about what the definition of a critical incident is. It is not a traumatic event. People think that bad things have to happen in order to activate that CISM peer support. A critical incident is any event that has the power to overwhelm the individual such that the emotions take over and their thinking diminishes, such that they are not able to reconnect with their proactive coping strategies. So imagine for a moment that you're in your early 30s, you have your first baby, and your baby is keeping you up all night. You're doing shift work and you're exhausted and you're going to work. And what you would normally cope with is really affecting you because you're so exhausted. Critical incident is not what happened at work. It's these other stresses in your life. When we look at rising mortgage rates and maybe your spouse lost their job and you're worried about economics and you're so stressed that you're not working out anymore, you're not eating healthy, you're not socializing. So what happens is what you would normally be able to cope with is harder to cope with. So this whole idea, and this is the part that just drives me crazy, is people say that they have a critical incident stress management program, and the number one thing that they do is they respond to traumatic events. Well, then you don't have a critical incident peer support program. And unfortunately, we have trainers out there that are making a ton of money saying, oh, we'll train your organization, we'll tell you what to do, that are not following the model. They are either retired members of a service, they're retired members in an industry, they are whatever background, and you're paying them a lot of money to get crap because they're not holding the training to the standard, and they are perpetuating the very problems that I just identified. They are running out to traumatic events. They're not teaching people to actually do what the model says, which is critical incident stress management, being integrated, letting people come when they need it, having an ability to check in, but also encourage people that it is safe to reach out for support and or help along that continuum of resistance, resilience, and recovery.
And it seems to me that ideally these fundamental principles need to start at the pre-service academy. And we need to address some of these things right up front. So things like financial issues, I think that should be something that should start week one of the academy to try and head off some of those stressors, give people these tools throughout, talk about the importance of sleep, because I think we're still in a phase with our profession where, and I think we're getting better at it, but we still perpetuate this myth that sleep is overrated. You can sleep when you're dead. It's okay, that the studs in the profession are getting by with 4 or 5 hours of sleep a night. And all of the evidence and science says that that is absolutely false. So is that part of this, to start this strategies right at the very start of people's career, at the basic academy, reinforce it through FTO, and then reinforce it continually throughout people's careers?
Absolutely. And I think that the problem that we have is when we have some, mental wellness committee that is made up of individuals from within the organization or within the industry, sometimes what we hear is, you're not going to tell us how to sleep. You're not going to tell us that what we're doing wrong. You're not going to tell us that, what we have perpetuated or learned or taught isn't credible or based in the evidence. And I think that that's a little bit of the resistance. Because you're right, people are perpetuating bad behaviors. But let's go back to what I said about proactive resilience. When in a time of stress, our thinking goes down, our emotions go up, our ability to access our coping strategies becomes more difficult. And in those moments, what happens is we default to what we've always done. So if proactively you had poor coping strategies, what do you think reactively you'll default to? poor coping strategies. Now, if I said to you, hey, tomorrow you're going to go and run the Calgary Marathon, what do you think is your prediction of whether or not you're going to complete that race?
Not very high. So in
But what if
fact,
I
I'd be
said,
out of town tomorrow.
me too. But what if I said a year from today, you're going to run that marathon? And what we're going to do is prepare you incrementally a little bit each day. What do you think is the likelihood that you would, what do you think you'd predict your likelihood of completing?
Probably pretty substantial if we did it appropriately over that year. Absolutely.
So what I find is amazing is that in the industry that you've worked in our first responders who really focus on, physical wellness, somehow what they think is the theories that apply below the neck have no relationship to the theories that apply above the neck. If you think about resilience like a muscle and like building muscle memory, how in the world do you think that you can recover from a critical incident if you've actually never done any sort of workout to prepare for it? And so we see individuals that are just this oblivious stigmatization of if it's something related to what, stigma above the neck, oh my God. But if we apply the same strategies to what we do with our physical wellness, we start to have people really understand the power that they have over their stress rather than feeling like the stress has taken the power away from them.
Excellent. Great explanation. Now, talking about peer support programs, and if we're going to implement one, I think a lot of times where we would start the conversation is selecting the people to be part of that. I get the sense that maybe where we should be starting the conversation is selecting the program that is evidence-based, that, well, let's take this evidence-based program and then let's figure out who the best people to train in that program is. Would that be accurate? Or
yeah, a couple of things, which is number one, don't presume that psychologists or mental health or psychiatrists or physicians are trained in this area.
Right.
We are not. We have to do the education, the training ourselves. So first of all, I think we have to be really biased of people in any industry of what they are promoting, selling, or whatever. There are very few programs that have stood the test of time and the rigor that would say that they're empirically validated, that there's scientific research or even information. So that's number one, that it is very rare to find people in my field, in fact, that are experts in this area. And I'm not saying in any way that I'm the expert, but I know how to read the science to decide which program is best for what population. Now, the other aspect about that is I think it's being able to say, how do you get the different levels within your organization on board? We look at how do you get that leadership buy-in, that it's a leadership supported approach. How do you get that middle level manager supervisor buy-in? And then how do you get the frontline buy-in? Well, the best way that we found, as you alluded to in the introduction, is we actually train leader peers not to provide peer support to the members of their organization, but other organizations' leaders. But what we're also doing is saying, here is the program that, as it is, you're educated enough to know what to do, but now you have no excuse to say you don't know what not to do. So when somebody comes to you and says, oh, we're going to change this because we don't like it, as a leader, you're able to say, no. I'll use the equation. Does anybody think that they have a better version of CPR? Are you willing to take the risk and say, hey, I know a better version of CPR. Let me try it out on you. I would be like, get away from me. Let's go with the science. Let's go with what we know works. So I think the first thing is, in the organizations that we have a lot of success in, is we look at these different tiers of educating the organization about what they should and shouldn't do. But you would be surprised at some of the pushback that we get that says, no, my frontline staff are telling me this is what they want. Okay. Maybe you have educated people. Maybe you have people that this is their passion, that have done the research. Well, then they should really be endorsing the same program the science does. Then what we do is we often see supervisors and managers who are often, again, They have a role more connected to the front line. They might see what's going on. They might know their members. And when there's changes from baseline, you need to get their buy-in so that people are free to activate the peer support when they need it, and that there is no barriers or encumbrances to the operation of the program. And I think the best way that we then look at it is, now what we do is when you have the leaders and the supervisors and managers trained, only then, when they understand what the program is, can they decide how to select the peers. And what we have learned over the last 7 or 8 years, and we're now more than 3,000 trained peers in the province of Alberta alone, is that we've learned that people that self-identify to want to be peers are not often identified by their peers as people that they will go to for support. So the first thing that we do is we say it's a nomination process. Who would you see as being a peer, and why? And we ask them to rate them based on these 4 or 5 characteristics. Then we interview them. Then we put them through the training. Then the trainer evaluates that individual's ability to be effective, to stick to the model, to deliver it in an effective way. And then only after that do we meet with them again and say, so do you think this is a good fit? And so only then does a peer become part of the peer support program or team. The other aspect is we hear these different departments that are training these peers, but they actually aren't working together as a team. There's very specific criteria that you need to have a peer support team. These are national standards. They are model standards and everything. So number one, you must operate under the supervision of a clinical director. We're dealing with people's mental health. Number two, you have to meet the basic minimum training. For the ICSF-CISM model, it's 4 days, both assisting individual and group crisis intervention. But we are seeing organizations who are just training either individual or in group, but not both. And that is a violation of the standard. We then have what we know, and again, being an enforcement, why do you need to recertify in things? Why do you need to constantly sort of, recertify or retrain? Because skill levels decline over time. So what we say is you must have regular retraining throughout the year in order to qualify to stay on as a CISM peer. And then what we do is we meet regularly with our peer support team to review what interventions they have had, and not who, but we're looking at what the peer is doing, the effect it's had on the peer, but also for peers who may not have been as active in providing peer support, it gives them the ability to hear what is going on out there. And again, it really is a way to sort of bolster or recharge the training experience. So again, if we look at the CISM, we don't, in our Alberta Critical Incident Peer Network, we don't train people and they're gone. When you train with us, I sort of say we're like cold sores. We keep coming back, which means that we actually make free training available, 1-hour refreshers on regular basis. We give the teams and the individuals the tools to do their job. And then what we do is we work with that team to make sure that they're following the best practice of the operation of the team. You should not have any peers operating as individuals. Final thing is this. We have a lot of EFAPs that say, we'll come do peer support. I don't know any EAP counselor that is a peer to your organization or the members. But we see that organizations, leaders, HR say, oh, we've got a contract with these big EAP providers and they do crisis intervention. They're going to come and do these interventions that have largely been taken from CISM peer support. And you're now going to have a mental health clinician, psychologist, counselor, whatever it is, facilitate this. And what we know is nobody is going to be open and talking. And what we see is the benefit derived by that approach is minimal.
Excellent. Great information. Now, there's a couple things that I want to talk about there. So if you talked about this, the criteria that the team is under the supervision of a clinical director. Now, if we look at the United States, in the U.S., there are 18,000 police departments. The vast majority of them are 50 officers or less. So there's a lot of small agencies. Yeah. So can you talk about identifying the right people to serve as that clinical director. And then the other piece is looking after the peer support people, their well-being, because I think we often forget about them, like we do so often, that the helpers don't get the help that they might need when they get continually exposed to some of these things. So could you talk a little bit more about those two elements?
Yeah, absolutely. So I'll use the example of Alberta. After the Fort McMurray wildfire, the Office of the Fire Commissioner realized that many members of the fire service went back to very small communities with very few resources.
Right.
And at the time, the fire commissioner said, Jeff, can we check in on these people and find out how they're doing? So we had people that were trained in peer support, and we called over 800 firefighters, paid on call, volunteer firefighters from small communities. We were able to get the list. We were able to phone them. We got permission from not only their chiefs and those sorts of things. So they knew that we were calling. And what we found is this was about 5 to 7 months after the Fort McMurray wildfires. We found that reaching out to those people were really struggling. We found a number of individuals that were actually suicidal. And based on that, what we were able to do is get a grant that said, so when we have these small departments of 35 people, or that, they're paid on call, they have full-time jobs, they just don't have the resources for the training or for the clinical, director, or for, paying for the programs. So I'll tell you what we did is we got a grant through all the Alberta municipalities that actually funds the material on a yearly basis that we give to our peers to use. The other thing that we do is we've created this provincial network, which is we have 160 small fire services that form this network. And it doesn't matter how big or small you are. You can be part of the network as long as you've trained with us, adhere to the standards. And like I said to you, what we do is we provide the refresher training, rotating probably 4 or 5 refresher trainings available to all of our peers every month. They have direct access to both a network coordinator, which is my colleague Malcolm, but also I act as the clinical director. Now, let me be clear. What do I get paid? Nothing. Because at my worst day, when I call 911, police, fire, ambulance, whoever shows up on people's worst day as a mental health professional who truly is invested in being put out of business so people can stay healthy, I donate my time to do it. So what are you looking for in a clinical director? Altruism, not somebody who's looking to make a buck out of you. Number 2, somebody who's trained in this and absolutely knows what the models are, the standards, and is trained in it. Otherwise, how can they support you in it? And I think the third one is sustainability. Somebody who's going to be around, somebody who's got a track record, but not a track record of creating clients to get them to the door to create clients, but somebody who truly believes in peer support and the benefit of preventing the injury, not having a referral base. And there are amazing clinicians and amazing organizations, few and far between, even in the province of Alberta, that are really committed to this, that we partner with, where our peers can walk individuals that need more to doors that we know. You are going to get clinicians that are not there because they want the business, but because they truly have a dedication to preventing these horrible career-ending, life-threatening injuries, psychological injuries. So those are a couple of factors that we look for. But, I've worked with an enforcement organization that sort of said, the reason for not working with me is they thought that I was too expensive. Well, I think that Sheridan has probably shared with you, I've donated over $1 million of my own money to develop this provincial network. I'm not making money on this. I'm giving it away. So that's my commitment. You're looking for somebody that has that commitment. And if people are interested in who that might be, they can reach out to me and I'll give them directions to people in this field that are good. Remind me of your second question.
It was helping the helper. So what do we do to make sure that our peer support people stay healthy?
Yeah. Well, we build it into, this is why it's so important to work as a team, that you're not just a peer, you're a member of a peer team. And whether that be our provincial network of a bunch of little teams that come together and operate under our umbrella, or you're part of a larger team that has that guidance, anytime you're activated, as a peer, somebody approaches you, whatever it is, there's sort of a post-incident or post-action check-in, either by a team lead. We have a criteria that says if you are providing support to somebody who's at risk for self-harm, you must reach out to me so that I can check in and say, hey, as a peer, what is that like? How are you doing? That is one of the most stressful things to do, to provide support to a colleague, coworker, or friend who's suicidal. So we have these post-incident reviews, but let me go back to it. You said that I'm involved in research. 2022 paper that was published is that when we train peers to do this and follow the model, and we offer them that regular refresher training and that consultation with the network coordinator or myself, when we're constantly updating them and checking them in, what we're seeing is their resiliency goes up. And we're really proud of the government of Alberta, the Spiffer grant through Labor, that funded the study that sort of says that not only is there a benefit to those receiving support, but by inherently being part of our network, receiving the training, sticking to the model, our peers delivering the program are more resilient. So
Excellent.
that's the answer to that question. It is inherent in the model. Yeah.
Excellent. Now, you've talked about a number of groups, and I mean, I think generally for, when people talk about public safety, first responders, they think police, fire, EMS, and I think more and more they're thinking about certainly emergency medical personnel, emergency room and trauma units and those things. It seems to me that a group that gets overlooked, that is exposed to a unbelievable amount of violence on a regular basis, are the corrections people. Can you talk about the importance of, because I think they tend to be overlooked in so many ways within this. Corrections and our 911 professionals seem to be two groups that seem to be forgotten about. So can you talk about the importance of those groups having these programs as well?
Yeah, well, in fact, let's go back to the CIPSRT Pan-Canadian study of impact. After EMS, dispatchers were second highest for rates of injury. So we absolutely know that sometimes sitting there taking those calls and imagining what's going on based on what you're hearing can be very, very impactful. And we have dispatcher and 911 comms peers as well, whether they be within the organization or separate. We do have comms peers. So that's absolutely recognized. I think the mistake that's been made is that you mix those in with the first responders who are on scene, and somehow them hearing what the first responders saw will actually help them. And in fact, we know that that's really detrimental. It's called vicarious trauma. So the organizations that we work with see that there's a need for peer support, but there's a different need or of type of support. So that's number one. Absolutely, we have so many of our dispatchers and peers trained, but there is room for growth and more. Absolutely. The next thing, which is corrections. Yeah, it is probably, and I would say that, if we look again at impacts, we know that doing that job, the type of work, the population that you not only work with, but also that who are your coworkers, there are those unique stresses that exist that are really, really not understood by any other organization, whether you be federal and or provincial. And I think that inherently what we have seen is really the struggle of there being a leadership-driven approach, that we see that while there are some pockets of peer support programs, number one, they tend to be reactive only. And number two, they seem to be organizationally driven. And what we're hearing over and over again, because we do get a lot of corrections people that reach out to our network because there is not the buy-in of wanting to call into their organization's peer support program. We have some really good people that are really working to make a change. We also see there's such resistance, which is, no, we're going to keep it the same. Our way works. Well, when you look at the rates of industries, WCB rates, when you look at the death due to suicide attempts, all those different things, I'll call BS on that and say, no, what you have isn't working. The statistics prove it. You might have something that you like, but it doesn't mean that it's effective. And there is such room for growth and opportunity there. But I think that what we've recognized, and there's a lot of research at a Memorial University, Rose Riccardelli, who works with the population, really understanding that there are cultural differences within corrections that need to be accounted for in order to put a program in place that people will use. And I think, unfortunately, there's a historical aspect that has a lot of people who could benefit from CISM and peer support or any program really cynical and skeptical about it. And it's going to take a lot of work to get their buy-in. So absolutely a need, but such a need to do work to make sure that how it is implemented is effective so that people will actually access it. I see a huge number of corrections officers in my private practice, by the way. And, I think if you're not in the industry, you don't really realize what you're exposed to, and the potential exposure. So yeah, huge gap. And that's an area that we are working on. Such resistance to it, though, by the way, both from leadership as well as frontline staff.
Yeah, and again, I think it goes back to the stigma is that there's still in a lot of places, and you talked about this earlier, and I've talked to people that say, you know what, we have all these programs and nobody will use them because you get labeled if you use them, and so people don't want anything to do with that. So you talked a little bit about buy-in, and I mean, really, in an ideal world, this should be an easy sell. This is the right thing to do to invest in our people. Almost nobody lives in an ideal world, so the pushback that a lot of play players going to get, their first question that they're going to get from some people in senior positions is, well, what's this going to cost? As opposed to seeing this as an investment that is ultimately likely going to save the organization substantial amount of money down the road, but that may be hard to predict. What would be some of the keys, strategies that you would recommend to people to get buy-in from the senior people that control some of these elements within their organization so that they can start to roll this out and in an effective way within the organization?
Yeah, well, first of all, I think that I'll go back to the CISM model. It really leverages a lot of the research and work done about what happens when you bring people together with a shared purpose and a model and a program. Is you start to sort of leverage altruism. You start to leverage that people want to do it because it's the right thing to do, not because it's the right thing for them to do for either promotion or whatever. Right. What we're seeing within organizations is we're seeing the leaders are sort of saying, hey, you guys strike a committee and you tell us what you need and you tell us what you need for a budget. And there's all this wasted time, money, and effort in recreating a wheel that is really coming out of ego rather than actually out of that altruism. And that's probably, if you want to talk about my stressor that's my stressor is when I see these things happening and that I keep saying, we have this thing that we will give to you for free. There's a little bit of an upcharge, a little bit of a small cost for the 4 days of training. But I just said to you that what we do is we literally put everything in the public domain and give it away for free. And I'm shocked at how there's cynicism about that. Well, what do you mean he's giving it away for free? There must be some catch. No catch. No catch. So I think that number one, leaders need to listen to people that are credible, not that are career oriented. Number two, I think that they really need to look at the science and understand the science rather than the sales pitch. And I really think that would they really strike a committee to do something that was outside the scope of their expertise? Would that make sense in any other world? So why would it make sense in a mental health world? So I think just recognizing that. I'm not saying come talk to me. What I'm saying is there are experts in this field that we can direct you to that you'll get unbiased and credible information from. Go with that consultation. A lot of us will do this for free, next to nothing free, because we have such passion about it. I think also being able to say that how can you create, I mean, if you let's look at corrections. They don't expect corrections officers to provide medical care because they do have usually a medical facility staffed by nurses and those different things in the facility. So there's a recognition of scope of practice. But when we start to talk about mental health in these programs, we get scope of practice creep. So there might be people that are interested in this, but the question is whether or not they're competent in it. So know the difference between interest and competence. Also, motivation. Is somebody trying to develop this because they want to use it on their resume, or is somebody trying to do it quietly in the background just because it's the right thing to do to look after their colleagues? That's a second. And then I think that look for programs that align. We have such siloed different programs. Buy this, buy this, buy this, buy this. Programs that are based in evidence tend to work together. So, for example, critical incident stress management, we partner with the Before Operational Stress program, federally funded, recognized, evidence-based, and there is synergy between saying that their program dovetails into our program, and then we have those supports. So what I would say is if you have organizations that are approaching you that don't work with other organizations on the continuum, you got to wonder why. Usually it's because people have approached me and we say, there's no science behind it, or you've just copied somebody else's program, so I'm going to go to the originator. So that to me is that skepticism. Don't buy one-offs. Go with people that are interrelated and linked, where the programs can be dovetailed and extended. And here's the other thing is, more expensive doesn't mean better. Our program that we do for 4 days of training, number one, we often get grants to run the program. So it's no or low cost. But at its most, even without a program, for 4 days of training, about $500 a person. That's pretty cheap training. And then we give everything else out for free after that. But just the training costs. There's material costs, certificate costs, right, booking of room costs, those sorts of things. We do it to sort of recoup the costs. Then, like I said, through grants, through Alberta municipalities and corporations and generous individuals, we give this away. So leaders knowing that, I think, can really start to say, well, why are we being told that we need this huge budget when in fact there's so much in the public domain?
And I think that grant piece is something we often overlook. We look for grants for ballistic shields and rifles and other things and fail to look for grants for some of these tools. So where do people start? So we talked at the start about your connection with ICISF-Canada, and then ICSF is also in the US. Where do people start looking for programs that are founded in the evidence and the research and the science?
So first of all, what I would say is go onto our website, ICISF-Canada.com. It's not the American website, it's the Canadian website. So ICISF-Canada.com. You can also look under the Alberta Critical Incident Peer Network, or the ACIPN.ca. And on the resources tab, you're going to find 100 pages of best practices and principles and guidelines that we have put in the public domain for people to take, use, print, download, whatever it is, to create the best model. Talks about how to select a trainer, how to establish the peer nomination. We have the interview questions. We have all of the forms in there, and we give it away for free to use. So when we see organizations paying somebody or striking a committee to develop a program, we're going, why are you wasting your time and money? Look at who created this. Look at who this is vetted by. It's people that are key in the industry. It's also our frontline peers. So that's what I would say is start there with the ICISF, International Critical Incident Stress Foundation Canada website. Under resources, best practice and guidelines, 100 pages of amazing information. Reach out to us based on where you're located or the program that you're looking for. Again, we have nothing but time to sort of sit down and say, what do you need? How do you want to go about it? And how do you make sure that you're selecting somebody to come in and either train or advise who's credible, who has the background, who has the knowledge, and really has the commitment to do this. So that's what I would suggest. I think that also respected people in the industry. One organization said to me, oh, yeah, we follow everything that CISM does. We follow their guidelines. And then when I say, then why are you doing those 4 things? Oh, well, yeah, but we've adapted the guidelines. Well, you can't have it both ways. So it's like, yeah, we follow it. Yeah, but. So, it really is saying there's so much out there that you're being sold. Be a skeptical, be skeptical of the sales pitch. And I'm not trying to sell you. I'm not trying to sell anything. I'm trying to give it away.
Yeah. And I think that's great advice when it comes to any training, is be skeptical about the sales pitch, because we see an awful lot of that in today's world. So,
and what I would say is if they are not a trainer with an accredited organization, if they just have their little shingle hung under the web where you can pay for training on their web, but they're not really affiliated with either ICSF or ICSF-Canada, that they've not signed a contract to adhere to the model to deliver, that they're not as approved instructors, if they're not monitored, mentored, that their fidelity isn't reviewed, stay away.
Excellent. Great advice.
Yeah.
So, Jeff, I want to thank you so much for carving time out of your very, very busy schedule to do the interview, and for such great information that you shared. But more importantly, I want to thank you for everything that you have done in this field, your tremendous contributions and your passion and your commitment and your service and your time and your money and your energy and your knowledge to serve the greater community here. And so for everything that you have done, everything you continue to do, thank you so much for those tremendous contributions.
Thank you so much. And I just say that anybody is welcome to reach out to me if they want to do an email. It's abcism, so Alberta CISM @shaw.ca. You can also give them out my phone number, 780-905-1923. I've also given the ICISF-Canada website, as well as the Alberta Critical Incident Peer Network, acipn.ca as well. Reach out and just ask questions. We have nothing but time to help you guys do the right thing, make the right decisions. And again, we're not going to charge you a consulting fee. We want to give it to you for free.
And that's so important. This is not a tick the box program. This is a long-term investment in our people, and we need to make sure that we're doing it right. So thank you so much for that. And so to the members of the Excellence in Training Academy community, as always, I encourage you to let the information that Jeff shared. He shared a lot of great information. Let that information simmer, percolate overnight, and be intentional. Sit down tomorrow. Write out your greatest takeaways. Write out your action steps. What actions are you going to take to put this information into motion in your organization, your training, to help your people? And so for the members of the Excellence in Training Academy community, as always, I thank you for your commitment to excellence both in and through training. Always continue to train hard, train smart, train with passion and purpose, and always be willing to dare to be great.
This interview was brought to you by Winning Mind Training Podcast. Brian Willis is a retired police officer with over 33 years of law enforcement training experience. Brian created the Excellence in Training Academy to provide practical, effective training for law enforcement professionals in leadership, mindset, and professional development for trainers. To learn more about Brian Willis and Winning Mind Training, go to www.winningmindtraining.com. The International Critical Incident Stress Foundation Canada is the sole Canadian partner to ICISF. ICISF Canada promotes best practices in the development and operational delivery of ICISF CSM teams for public safety and healthcare organizations across Canada. If you'd like to learn more about how you can develop a CSM team that adheres to high fidelity to the ICISF model and best practices in peer support, go to ICISF-Canada.com, and you can also reach us on our info line at 1-780-953-2476. The Alberta Critical Incident Peer Network is a peer-led, peer-driven peer support network in Alberta. With over 400 volunteer-trained peers representing over 150 public safety personnel organizations that include fire, EMS, search and rescue, and dispatch. If you reside in Alberta and you'd like to learn more about how you can develop an integrated CSM team, as well as join this robust provincial network, go to abcsm.ca, that's AB as in Alberta, CSM.ca, or contact our info line at 780-953-2476. On our website, you'll find a plethora of resources, including documents that describe what a CISM team is, how CISM teams operate, as well as a 10-step planner for preparing for developing a CISM team. For those who join ACIPN and train with ACIPN, they get access to continued current templates for SOPs, activation algorithms, as well as access to monthly refresher training to maintain skills and real-time consultation to a clinical director and a CISM network coordinator, as well as post-action support for peers providing this essential service. To activate peer support in Alberta, any individual, crew, or department who may be impacted by a bad call, heavy workload, or personal life stressor by calling 1-833-894-2476 anytime, 24/7, 365. This number is answered by a volunteer 911 comms dispatch center, and they will provide a callback with a respective peer.